All right, welcome everyone. This is the ASE board review course. This lecture is on cardiac masses and cardiac sources of embolism, and my name is Akhil Narang. There's a number of questions that we should ask if you visualize an echocardiogram with an intracardiac mass. I think from all purposes, we should first consider where is this mass located? What is the differential diagnosis? What are the anatomic and morphological features of the mass? So what is the appearance, size, shape, extent, and spatial relationship of the mass to adjacent structures? What is the clinical presentation and clinical consequences of the mass? And what are the potential treatment options? And so today's lecture will go through everything that you can think about with respect to intracardiac masses and tumors. Now, the fundamentals a little bit on this. Echocardiography, as we all know, is often the first imaging modality to investigate cardiac masses. We often use ultrasound enhancing agents, also known as contrast and 3D echo in recent years, that have really enabled for more accurate assessment of masses. We also have now transillumination technologies that can help characterize these masses as well. Both transthoracic and transesophageal echocardiogram are helpful, but we do invoke in these days multimodality imaging, especially with cardiac MRI, CT, and PET. The clinical presentation of masses can be numerous. This includes obstruction, interference with valvular structures that result in regurgitation or stenosis, invasion of the myocardium or pericardium, which can sometimes cause pericardial effusions. It can also impair myocardial contractility, lead to rhythm disturbances, cause embolization, and also have a number of constitutional and systemic symptoms. Now, the differential diagnosis for cardiac masses, these are broad categories, and we'll go into each of these categories with more detail. First, we can actually see normal anatomy and anatomic variants that can sometimes mimic masses. We can also see artifacts. There are also is a category of implanted cardiac devices and structures. These are transcatheter therapies or interventions, surgical valves or devices that can sometimes be mistaken for masses in the right echo context. Vegetations, of course, these are infectious. These are acute or chronic. Thrombus or clot, again, acute or chronic. And then tumors, either primary cardiac tumors or secondary or metastatic cardiac tumors. This schematic breaks down cardiac masses. It's a busy slide, and I encourage you to take the time to come back and review it. Very briefly, we can break down the cardiac mass into either intracardiac or extracardiac masses. If we think about the category on the left of intracardiac masses, we first look at normal variants and iatrogenic things, and we'll talk about each of these, breaking it down by right atrium, left ventricle, left ventricle. And then we have a category of non-tumor mass-like pathology, which has a number of possible differential diagnoses, and then tumor. Within the category of tumor, like we talked about earlier, we have primary tumors, which can be benign or malignant, and then secondary tumors, which can actually be caused by direct extension from another tumor, hematogenous spread, venous spread, or lymphatic spread. When we think about extracardiac masses, the two buckets that we think about are the pericardial or other. Within the pericardial category, again, there's a benign and malignant variety, and then there's a lot of miscellaneous things that are extracardiac, which can be seen here. So I encourage you to come back to the slide and review it in a little bit more depth. Let's start with the question. So what is the structure indicated by the arrow? Since this is all virtual and you can come back and look at the lectures at your own speed, we won't necessarily leave many pauses in between questions here. The answer, of course, is a left atrial appendage occluder device. And we'll talk more about this in going forward, but you can see something that looks like it's a man-made figure 8 structure here, which in this case is a left atrial appendage occluder device. First, talk about normal anatomy. I think normal anatomy, as we mentioned, gives the baseline establishment for what potentially can be abnormal. So there are a number of normal anatomic findings in echocardiography that can be mistaken for cardiac masses. This list includes most of the variants of normal anatomy that you might encounter on the boards or just in real life. And so know this list very well, keep it handy, and this might save you questions from referring physicians down the line if you include this information in your report. When we look at the right ventricle, there's moderator bands, trabeculations, and papillary muscles that can look like cardiac masses. If we look at the right atrium, we see the Chiari network occasionally, eustachian valve, and crista terminalis. In the left ventricle, we can see false tendon or chordae, focal hypertrophy of the myocardium, papillary muscles, and trabeculations. Even diverticulum I would add to this as well. And in the left atrium, you can see pectinate muscle in the left atrial appendage, Coumadin ridge, the transverse sinus actually, and then in the intraatrial septum, you can see lipomatous hypertrophy and atrial septal aneurysms, all of which can mimic cardiac masses. So we'll start with the Chiari network first. The Chiari network is a mobile net-like fenestrated often structure that can be visualized in the right atrium near the IVC junction or near the coronary sinus. It is the embryologic remnant resulting from incomplete reabsorption of the right sinus venosus valve that persists as a reticular network. Here are a couple of videos that show prominent Chiari networks that demonstrate this net-like structure whipping back and forth in the right atrium. In the TEE view on the top right, you can see that it's actually partially prolapsing into the right ventricle as well in a more exaggerated form. The Chiari network has actually no clinical significance really. It can sometimes cause problems with respect to transcatheter therapies, but other than that, it really can have no clinical significance. Rarely, however, it can be associated with thrombus formation, entrapment, as we talked about from transcatheter technologies, or even infection. Now, the difference between the Chiari network and the eustachian valve is that the eustachian valve has one attachment point usually, while the Chiari network has multiple attachment points. So coming on to the eustachian valve and the crista terminalis, the eustachian valve is a remnant of the embryological right valve of the sinus venosus. In utero, it directs oxygenated blood, as we know from the IVC, to the foramen valvae into the left atrium. The eustachian valve has one attachment point, like I mentioned, and the Chiari network has multiple. The eustachian valve is usually benign, often an incidental finding, and very rarely can have complications such as infection or thrombus formation. The crista terminalis is a C-shaped or crescent-shaped muscular ridge that spans from the anteromedial wall of the right atrium near the SVC orifice, and it's directed towards the IVC typically. Occasionally, it can merge with the eustachian valve, and the embryologic regression of the septum spurium at the sinus venosus is incorporated into the right atrial wall. The sinoatrial node lies superior to the crista terminalis, and so this is just relevant adjacent structures that you should be familiar with to recognize what these look like, both the eustachian valve and the crista terminalis. Pectinate muscle are small muscles that lay perpendicular to the body of the left atrial appendage, and they can sometimes be mistaken for thrombus. The difference between pectinate muscle and thrombus is that usually with thrombus, there's an independent motion of the cardiac mass that you're seeing within the left atrial appendage, whereas pectinate muscle really don't move in such a fashion. They're typically small and linear, whereas thrombus can be more irregularly shaped. So the top two videos show pectinate muscle, top two clips show pectinate muscle, while the bottom video shows our left atrial appendage thrombus. So they look very different. The top left video, you can see these pectinate muscles that are the small muscles that lay perpendicular to the body of the left atrial appendage. The Coumadin ridge separates the left atrial appendage from the left upper pulmonary vein, so know this anatomy very well. It's particularly important in structural interventions of the mitral valve or left atrial appendage occluder devices. The Coumadin ridge can sometimes be very prominent and can be misdiagnosed as a tumor or a thrombus, and sometimes it's called a Q-tip. It resembles a Q-tip in many instances. You can actually see this occasionally in transthoracic echocardiograms as well, as shown in the right-hand picture over here, where there's a very prominent Coumadin ridge. But this is not, again, an intracardiac mass. And if you did the TEE in that patient, you would see that this is just a very prominent Coumadin ridge. So looking at the motion of these masses with respect to the cardiac cycle is actually very important as well. Next, we'll talk about lipomatous hypertrophy of the intraatrial septum. As we know, this is not an uncommon thing that we see excess accumulation or thickened adipose tissue at the intraatrial septum, and it results in what looks like a mass, but in fact, if you look back sometimes to historical echoes if they're available, is just lipomatous hypertrophy. This looks like a dumbbell in appearance, and that's how it's been described in many ways. And then this is a very exaggerated example of this, of a bicable view TEE showing significant lipomatous hypertrophy of the intraatrial septum. This can make it challenging for structural procedures in order to cross the intraatrial septum. So the transverse sinus is a potential pericardial space between the ascending aorta and left atrium. And when pericardial effusion is present, when there's fluid in that space, the apex of the left atrial appendage can actually appear like a mass within the space. And it's been described as a thrombus in the past before. So just make sure that you don't get confused by this. The transverse sinus can actually also be confused with the left coronary artery. And so these are a couple examples of the transverse sinus. In figures A, B, and C, you can see the transverse sinus marked with an asterisk. And in figure D, and the top right images and the top bottom images, you can see the transverse sinus marked with an arrow. Of note, in the bottom right image, this is a TEE that shows the tip of the left atrial appendage marked by the asterisk on the TEE imaging in the transverse sinus. And so if you flex your probe, you're able to see the tip of the left atrial appendage. And again, this is not tumor, this is not thrombus, this is just the tip of the left atrial appendage noted in the transverse sinus when a pericardial effusion is present. Now, moderator bands coming to the right and left ventricle. Moderator bands in the right ventricle is a muscular band of heart tissue found in the right ventricle of the heart. This is shown in the left-hand figure. And in the middle figure, you see a false tendon of the left ventricle. Sometimes it can be mistaken as masses. And then on the right side, we see excess trabeculations of the LV on short axis, which can be seen in a variety of conditions, including non-compaction cardiomyopathy, occasionally dilated cardiomyopathies. And just recognize that these are trabeculations and not tumor themselves, although tumor can be found within the crypts, the deep crypts of trabeculations. Mitral annular calcification commonly occurs in patients who are older or those who have end-stage renal disease. And then when you have a component of mitral annular calcification that develops liquefaction within the MAC, you can start getting this liquefactive necrosis, and this causes caseous MAC or caseous MAC. On resection, this liquefied component has been described as toothpaste-like, and it's consistent of cholesterol, fat, and calcium. And so here are a couple examples of significant mitral annular calcification, both from transthoracic and then the surgeon's en-face view on the top two images over there. The bottom images show liquefaction necrosis of caseous MAC that results in caseous MAC. And so you can see this echo-dense rim and a center that's a little bit more fluid-like that again is consistent with cholesterol, fat, and calcium. But turning our attention now to intracardiac devices that sometimes can be mistaken for masses or intracardiac masses. This obviously can be mistaken in poor imaging or incomplete imaging, and occasionally if there's complications from intracardiac devices. Generally, these devices include pacemaker and ICD leads, venous catheters, left atrial appendage occluder devices, septal occluder devices, prosthetic valves, and valve repair devices, and also transcatheter therapies as well, which is an upcoming field. So just a couple examples of what an intracardiac lead looks like on the right ventricle. Here are pacemakers and ICD leads that we see both on transthoracic imaging and then also, so these are transesophageal imaging with 2D and then also 3D with transillumination. On the left-hand side, you can see that this intracardiac leak is probably also resulting in significant malcoaptation of the tricuspid valve leaflets, resulting in significant tricuspid regurgitation. Venous catheters, there's a lot of different venous catheters and support catheters that are being used in the critical care world now. So having a familiarity with these are important. Looking into the patient's chart is important as well. The left video shows a transthoracic echocardiogram of a deeply placed venous catheter with an attached thrombus to it. So you can see within the right atrium that there's a lot of excess mobility of this echodense structure here. And this is unfortunately a thrombus that's been associated with a deeply seated venous catheter. On the right-hand image, you can see a transesophageal view looking at the RVOT, and you can see in this case, there's a PA catheter that's crossing the pulmonic valve and going into the pulmonary artery. These are examples of left atrial appendage occluder devices. This is the example I showed in the question on the left over here. And this is a figure of 8 artifact actually noted in the left atrial appendage after an occluder device has been placed. And then on the right-hand images, you can see some more still images of occluder devices, left atrial appendage occluder devices, and what they look like both on echo, 2D echo, 3D echo, and then also fluoroscopy. Atrial septal occluders, there's quite a number of them, typically look like a bulky structure, man-made, echo-bright structure that separates the left and right intraatrial, left and right atriums across the intraatrial septum. Here are a few examples of them from transthoracic echocardiography on the left-hand side. On the middle top, there's a transesophageal echocardiogram with a bicable view showing an intraatrial occluder device, and then also in the figure on the right-hand side as well that shows it also in 3 dimensions. It kind of looks like a dumbbell with a small central component. That's the most common type of atrial septal occluder devices that are noted. Again, prosthetic valves and repairs can look like intracardiac masses, so we have to be careful that we're not mistaking prosthetic valves or valve repairs for intracardiac masses. The top left shows a Medtronic monoleaflet aortic valve prosthesis with normal valve function. So you see the artifact there. Then you see in the top middle a bileaflet mechanical mitral valve. On the far right top, you see a bioprosthetic mitral valve. The bottom left, you see a bioprosthetic aortic valve. Again, you can see the madman material hugging the LVOT. The middle bottom, you see a TAVR on short axis. On the bottom right, you see two mitricles that were placed across the mitral valve. And so these prosthetic valves were becoming more and more common, either mechanical or transcatheter or bioprosthetic, and just recognizing, especially with all the many transcatheter trials that are upcoming, what these look like on both TEE and TTE. Okay, we'll go to another question now. This is a 76-year-old male who presents to the emergency room with acute onset shortness of breath and chest pain. A bedside echocardiogram was obtained. Which of the following is the most likely explanation for the patient's symptoms? So you see here a large right ventricle. The LV function looks fine. The LV comparatively looks much smaller. And you see an echodense structure that's traversing from the right atrium across the right ventricle. And of course, this is a pulmonary embolism with clot in transit. So thrombus is a large category of intracardiac masses that we will see. Thrombus, again, is the most common actually cardiac mass noted. And if we look at the left ventricle, we see left ventricular thrombus mostly occurs after myocardial infarction, acute myocardial infarction, that results in left ventricular wall motion abnormalities and stasis of blood. Most commonly, we see this in the apex, but it also can be seen in other aspects of the LV, the left ventricular chamber itself. We tend to see the apex involved mostly with an LAD infarction. So if that's part of this question set that's given, that's what your suspicion should be raised with. These thrombi can be formed within 24 hours after acute MI, and 90% of them form usually within 2 weeks after acute myocardial infarction. The incidence has been reported to be 5 to 15% of all MI patients, and I think this was decreasing in the contemporary era with PCI, but recognize that a non-trivial amount of patients with myocardial infarction will develop thrombus. We often want to use contrast in these situations to be able to highlight this a little bit better, so that's one thing to keep in mind. When patients who have LV systolic dysfunction or dilated cardiomyopathies, again, sometimes you can expose the crypts and the trabeculations, and these are more likely to form thrombi in there as well. One report suggested the incidence of a left ventricular thrombus is up to 50% in patients with severely depressed ejection fractions, less than 20%. And interestingly, in patients with severe MR in these situations, it might actually be protective and not allow for thrombus to form within the left ventricle because of all the blood that's forming in these situations, particularly in the left atrial appendage. We can see thrombus in hypercoagulable states and also superimposed at intracardiac masses. Specifically, patients with endocarditis can have superimposed thrombus. We can also see thrombus not infrequently on intracardiac devices, particularly pacemaker or ICD leads. The differential diagnosis we talked a little bit about, but includes trabeculations in the LV, false tendons, tumors, apical hypertrophy, hypereosinophilic syndrome, and then also even artifact. So here are a few examples now of thrombus within the left ventricular apex. You can see pretty clearly without contrast on the left-hand image that there's a significant thrombus burden there. There's wall motion abnormalities, poor LV function, and results in thrombus in the left ventricular apex. The middle image, you see another aspect where you see the akinesis of the apex of the heart, and there is mobile thrombus there as well. And the right-hand image, you see a pedunculated apical thrombus, so there's a little bit of a stalk that's associated with here, and highly mobile as well. A few more examples of why it's important to use contrast. Well, on the left-hand image, we see here that the basal and mid segments are contracting reasonably well, whereas the apical segment is akinetic. We go slightly off axis and we see something that looks like there's a potential filling defect there. And after administration of thrombus, it really becomes much more obvious. So what are some predisposing conditions for left ventricular thrombus? There's a list of them that are shown on this slide, and I won't go through all of them, but come back to the slide and please pay attention to them. There are many things that can cause left ventricular thrombus, or at least be a predisposing or risk factor for them. So thrombus can also form in the left atrium or left atrial appendage, and it also form in the right heart as well. Right atrial appendage, which again is a little bit harder to visualize and less common than the left atrial appendage. You can also see catheter-associated thrombus, which we mentioned, clot in transit or pulmonary embolism, and then also even within RV trabeculation. These are examples of left atrial appendage thrombus. You can see here hypermobile structure that's independent of the cardiac cycle on images on the left. And on the middle image, you can see here during a portion of the cardiac cycle that the thrombus is actually extending into the left atrium in the middle of the cavity. And then on the right-hand image, you see a 3D en-face view of the left atrial appendage with mobile thrombus noted if you look carefully as well. It's right over here. Left atrial appendage thrombus, you can see this in cases of in situations of mitral stenosis. There's a bicable view of a patient with a large thrombus sitting on the intraatrial septum. And on the right-hand image here, you see significant mitral stenosis with resultant left atrial thrombus. Here are examples of right heart thrombus on the left-hand side. This is the image that we showed in the question. This is clot in transit. On the top right, this is a dialysis catheter that's been tunneled too deep into the right atrium with associated thrombus that is propagated to the RVA free wall. And you can see the catheter on the right-hand panel here. There's probably thrombus that formed on that and then again propagated to the other wall, the opposite wall. The bottom we see IVC thrombus that's threatening to mobilize as well. A few more examples of right heart thrombus. On the left-hand video, you see right atrial appendage thrombus, and on the right-hand side, you see right ventricular apical thrombus. Okay, moving to another question. This is a 54-year-old female with a history of mitral stenosis and prior mitral valve surgery 3 months ago, who's admitted for progressive fatigue. Her admission INR is 2.9. What is the most likely explanation? So I'll let you look at the video for just a moment. And the answer, of course, is prosthetic mitral valve endocarditis. You can see there's hypermobile structures independently of the cardiac cycle attached to the mitral valve, by the mechanical mitral valve here. So vegetations and endocarditis is the next category. The location can be in valve surfaces. In patients who have congenital heart disease, it can be opposite of an intracardiac shunt. What that means is if you have an ASD with left to right flow, you can have vegetations that are on the RA free wall. You can have vegetations that occur on prosthetic materials or devices. That includes valves, of course, and also intracardiac leads. When it comes to the valves, you tend to have vegetations that are mostly on the atrial surface of the mitral valve and the ventricular surface of the aortic valve, although this often can be in the opposite direction as well, or go both between both surfaces of the atrial and ventricular side for mitral valves, and also for the aortic valve, the ventricular and the aortic side. The characteristics of vegetations and endocarditis include mobility. This tends to be one of the most characteristic things that we notice about them, that they're independently mobile of the cardiac cycle. They oscillate, they're quite heterogeneous in appearance, and they often have multiple lobes. And the echogenicity might be different from surrounding nearby tissues. And so paying attention to what the myocardium echogenicity is and comparing it to what you might see in a valve gives you a suspicion that something could be an infectious process going on. Now, chronic or heel vegetations that can actually become calcified. So not all infective endocarditis end up in surgery. Sometimes they're treated just medically with antibiotics, and over time they can become calcified and less mobile. Now, obviously, we know the consequences of vegetations or endocarditis include valve regurgitation and or stenosis, especially with larger vegetations that actually obstruct the valve. The lesions can be infective or non-infective, meaning if they've been treated with antibiotics for quite some time, they actually might be sterile. But we can see superimposed thrombus. And sometimes when people have septic emboli, it's not necessarily the remnants of the infective vegetation that's embolizing, but it might be thrombus on top of that that's embolizing. And the sensitivity for detecting infective endocarditis by transthoracic echocardiogram is low. It's 50%, ranging from 30 to 70% in studies. And with TE, this is why we do TE, the sensitivity is much higher, greater than 90%. So here's an example of a mitral valve endocarditis. You can see extensive involvement of the posterior mitral valve leaflet on the left-hand image, and then on the right-hand three-dimensional image involving, again, the posterior leaflet near P1 commissure and the scalp, near the P1 scalp and also the commissure. Here's an example of aortic valve endocarditis. You can really see that the aortic valve was quite destroyed in the left-hand image. The cusps of the aortic valve have multiple vegetations on them. And then on the right-hand image, we see that there's significant endocarditis noted as well, bulky, dense, highly mobile echo structure noted as well. Here's an example of mitral and aortic valve endocarditis. These are still pictures. The mitral aortic infective endocarditis is seen here. So this is a patient with aortic valve endocarditis that's probably extended to the mitral valve, and it's caused perforation of that mitral valve, resulting in severe mitral regurgitations as well. And you can see the three-dimensional image right here with the red arrows depicting the perforation of the anterior mitral valve leaflet. You can see tricuspid and pulmonic valve endocarditis in IV drug users, especially patients with dialysis catheters or other venous catheters or pacemaker or ICD leads in the right heart as well. And so here on the left-hand side, you see a large tricuspid valve endocarditis, and the right-hand picture is a still image showing there's a vegetation on the pulmonic valve from a TEE. Prosthetic valve endocarditis can unfortunately occur as well. This is the image I showed in the question on the left-hand side, mechanical mitral valve endocarditis with vegetations. And on the right side, we see, on the right middle, we see a bioprosthetic aortic valve endocarditis with paravalvular abscess. You see the thickened material adjacent to the aorta. That's all suspicious for abscess formation. And on the lower right, we see what is a TAVR valve that's developed TAVR endocarditis. So there's a mobile structure on the TAVR valve itself. Now, morantic endocarditis is also known as non-bacterial thrombotic endocarditis. And this is a deposition of sterile. So again, we talked about sterile and non-sterile endocarditis. This is sterile platelet thrombi on the heart valve, mostly the aortic and mitral valve. It's non-infectious, mostly impacts the aortic and mitral valve. And this diagnosis should be suspected in patients who have acute stroke with either underlying cancer, lupus, or antiphospholipid antibody syndrome. So those three things can result in morantic, non-infective, non-bacterial thrombotic endocarditis. And the treatment usually consists of anticoagulation and treating the underlying malignancy or associated condition. Sometimes surgery or excision is performed, although it's quite rare. Okay, another question. So this is a 33-year-old female who's referred for a baseline echocardiogram prior to starting chemotherapy for newly diagnosed breast cancer. What's the most likely explanation here? And we can see on the mitral valve, there's a round regular structure that's noted. Again, the history suggests the patient otherwise has no issues. This is a surveillance echocardiogram. This is most likely a papillary fibroblastoma. So now we'll talk about primary cardiac tumors. This is the breakdown of primary cardiac tumors. Most of them are benign, 80%, and 20% are malignant. To know these lists very well, these lists are important to know. The most common benign primary cardiac tumors are myxomas, papillary fibroblastomas, lipomas, rhabdomyomas, and fibromas. From the malignant side, you can see a lot of sarcoma here, lymphoma, mesothelioma, teratoma, and a few other things that are more rare. We'll start with myxoma first. So myxoma is the most common adult primary cardiac benign tumor. The presentation can be quite variable. It can be incidental. It can be subtle constitutional symptoms like low-grade fevers, chills. It can actually be heart failure if it causes obstruction of the mitral valve, syncope, stroke if there's superimposed thrombus, embolic events, and even obstruction. Most of these cases are sporadic. 10% are familial, so it's important to take a good family history. In terms of the location, 75% are located on the left atrium attached via a pedicle or stalk to the intraatrial septum near the fossa ovalis. Less frequently, but still not unheard of, we can see them in the right atrium or even in the ventricles. 2 to 5% actually recur after resection, so they do need surveillance imaging periodically. And on echocardiogram, they appear to be smooth in texture. So here are a few examples of myxomas in the left atrium. On the top left, you can see a large left myxoma that's occupying the entirety of the left atrium and it's prolapsing briefly across the mitral valve. The middle picture we see, middle video, we see a prolapsing myxoma across the mitral valve as well, attached to a stalk on the intraatrial septum. And then we see a three-dimensional version of this on the right-hand picture over here. Another example of a left atrial myxoma that's prolapsing across the mitral valve and it's associated M-mode tracing. This M-mode tracing you absolutely need to know. It will show up in your boards. And you can see again on the left-hand picture, it's a mobile structure that's pretty smooth in appearance. This one has a few lobules associated with it, but it's attached to a stalk on the intraatrial septum. And we talked about atypical locations of myxomas as well. This is a right atrial myxoma. It has the same appearance. This is the left-hand picture with a large mass attached to a stalk in the intraatrial septum. You can see this is causing functional tricuspid stenosis, so very significant obstructive disease that's being caused in this particular case. And we mentioned valvular myxomas as well. And again, not as common, but they can happen, where we see small structures that are associated on valves. These are different. These are hard to differentiate sometimes from papillary fibroblastomas. So if you see an image like this, papillary fibrobblastoma is still going to be your first thought, but do recognize that occasionally when we resect this, we get histology back and are surprised to find out that indeed it's a myxoma. So let's move to papillary fibroblastomas right now. This is the second most common primary benign neoplasm in the heart. These are usually round solitary lesions that are located on the aortic valve, commonly in the mitral valve. These are much more common than the other valves, tricuspid valve and pulmonic valve. And rarely are they on endocardial surfaces as well. They can be located on either side of the valve, and they typically have a frond-like surface and a shimmering appearance. They tend to be in the mid portion of the valve, unlike Liebman-Sachs endocarditis, which is along the coaptation points of the valve. Again, these are often discovered incidentally, but they do carry with them an increased embolic risk. And so occasionally we will identify this in a patient who had a stroke, and we have to then suspect that this is the etiology, especially if it's on the left side of the heart. They generally don't disrupt valvular function like myxomas because they don't cause obstruction. And again, they're non-vascular, so they will not enhance with contrast. The differential diagnosis is shown here, but does include endocarditis, especially in the case of positive blood cultures, Lambo's excrescens, which are different from papillary fibroblastomas. These tend to be wispy, small, linear structures. We'll show examples of these in a few minutes. So these are examples of papillary fibroblastomas, all of the aortic valve on top and the mitral valve on the bottom. And you can see that they're smooth, round-like structures that you're seeing attached to the valve surface. Here are examples of papillary fibroblastomas that are perhaps a little more atypical. On the left-hand side, we see them a tricuspid valve. In the middle, we actually see a fibroblastoma attached to the papillary muscle. And then on the right-hand side, we see one that's attached to the pulmonic valve, and that was resected and had the consistency of a papillary fibroblastoma. Okay, so now we'll talk about Lambo's excrescens. So these are fairly common. The incidence is 5 to 6% of the general population that are referred for a TEE of any indication, and 40% of patients with cryptogenic stroke refer to a TEE. So you can tell already from this demographic that patients with stroke sometimes have these in about almost half the cases, and they can be associated with stroke. They're thin, hypermobile, linear, filiform strands, usually located at the coaptation lines of valves. Most commonly occur in the mitral valve, the atrial surface of the mitral valve, and the ventricular surface of the aortic valve. Rarely do they occur elsewhere. Again, they're also non-vascular. They do not cause valve dysfunction. And again, they can be an incidental finding on asymptomatic patients, but they can be the source of stroke in patients who are being evaluated with TEE. The differential diagnosis includes thrombus vegetation. I would probably add in papillary fibroblastoma, but it does look discrete, different from all three of these differentials. Here are examples of Lambo's excrescens on the aortic valve. As you can see here, really no problems with the aortic valve with respect to obstruction or regurgitation. And it's a small, thin strand, as you can see here, if you pause the frame and look at it and zoom into it. Here's a list of more primary benign tumors that you can see in the heart. Rhabdomyoma and fibromas are the most common benign cardiac tumors in children. So if you get a question asking about children and a benign tumor, these are the things that would be at the top of your differential. Both rhabdomyomas and fibromas can be seen associated with conduction disease, arrhythmias, or even sudden cardiac death, although it's quite rare. In terms of rhabdomyomas, they're muscular. They typically are located in the left ventricle, and they're associated with tuberous sclerosis. So if that's part of the history you're given in your STEM, you should think about rhabdomyoma. Sometimes we can see this regress spontaneously over time. Fibromas are tumors that are usually within the anterior or septal wall of the LV or LVOT. And there's a few other things listed on the right-hand side here, which are much less common. This is an example of a rhabdomyoma that regressed over time. And you can see this large echo density on the left-hand structure that 4 years later resulted in complete elimination after treatment. And here are examples of fibromas. Again, I mentioned to you that these are often within the myocardium or the left ventricular wall or outflow tract, and you can see examples of thickening of the myocardium here. both on the top hand panels and the bottom hand panels, and also on the moving image here. These are all consistent with fibromas. Again, much more common in children than in adults. Okay, let's move towards malignant primary cardiac tumors right now. The vast majority of them are going to be some sort of sarcoma. And there's a lot of sarcomas, a lot of varieties of sarcomas. These include angiosarcomas, which are most commonly on the right atrial side of the heart, sometimes more in the right heart in general. These are much more invasive, highly malignant, and they can cause a lot of metastatic disease to other portions of the body, including lung mets. There are other forms of sarcomas as well, which are left atrial more common. These are undifferentiated rhabdomyosarcoma, fibrosarcoma, leiomyosarcoma, and osteosarcoma. Much less common, we can see mesotheliomas, which also involve the pericardium, lymphomas, and paragangliomas. And so here are a few examples of angiosarcomas located on the right side of the heart. You can see these large masses here. You will be given, usually in your stem of the question, an example of a patient who has constitutional symptoms, has a suspicion for malignancy, or something that makes you suggest that this is more than an incidental finding. And this is a resected angiosarcoma on the top right here. And you can see the heterogeneity of this tissue as well. These are mesothelioma and lymphomas, much less common, again, often involve the walls or the cavities of the heart. Some of them can really cause a lot of obstruction and cavity narrowing, as you can see on the right-hand side. Secondary cardiac tumors are less common, much more common than primary cardiac tumors. I meant to say that primary cardiac tumors are much less common than secondary tumors. And this is by the order of 20 to 40 times more common to see a secondary metastatic cardiac tumor than a primary cardiac tumor. Reports of 5 to 15% of oncology patients have some sort of metastatic extension to the heart or the pericardium. And so when you have an oncology patient that presents with cardiovascular symptoms, you have to think about metastatic disease. These are most commonly seen in patients that have cancers that are known to be highly metastatic. Breast cancers, lung cancers, melanoma has a high likelihood of cardiac metastasis as well. And then overall, the sites of metastasis tends to be mostly the pericardium, which can cause effusion, much more so than the myocardium or the endocardium. Now, how secondary cardiac tumors spread depends on a couple of different factors in the type of tumor itself. And so here's a schematic that depicts this. So if we talk about direct extension, we're thinking about breast, lung, esophageal cancers, and mediastinal tumors. If we think about spreading hematogenously through the red blood cells, melanoma, lung, breast, GI, GU cancers. There's venous extension. These tend to be through the IVC, renal cell carcinoma, uterine carcinoma, and then hepatocellular carcinoma. And they can extend to pulmonary veins as well, lung, breast, thyroid, and some spread via the lymphatic system, such as lymphoma or leukemia. Here are examples of a patient with malignancy who's noted to have a mass in the IVC on the left-hand side with extension into the right atrium. This is most commonly seen in renal cell carcinoma, hepatic cell carcinoma, or uterine cancer. So these are the things to think about if you see these IVC tumors or heterogeneous structures that are extending then to the right atrium. You can see the tip of the tumor extending to the right atrium here on the right-hand picture as well. This is another example of a metastatic melanoma that's involving the apex of the LV. And you can see this over here. This patient, you would have the clinical context of a melanoma with intracardiac mass, and then you should really think about metastatic extension. This is an example of tumor thrombus from testicular cancer on the left-hand side, extending via the pulmonary vein into the left atrium. So these are quite rare, but can be seen occasionally. And on the right-hand side, we see a large lung cancer that's metastasized and spread into the left atrium through the pulmonary vein. There are extracardiac masses that we can identify in echocardiogram as well, most commonly the pericardial cysts. So pericardial cysts are usually seen at the right costophrenic angle. Often we see these better with MRI or CT, but you can occasionally see them in echocardiograms as well. And they often appear as echolucent, almost like an effusion space, and they can actually cause extrinsic compression of the right atrium or the right heart structures. And so you can see this echolucent space right here is actually known as a pericardial cyst when looked at with further imaging. Now this is an example of a renal cyst. So once in a while we can catch these as well on echocardiograms as part of the extracardiac manifestations of ultrasound. This is an example of a large renal cyst that's invaginating the liver, which is shown by the arrow. So that echolucent appearance you see in the subcostal view, but it's actually a large renal cyst that's impinging upon the liver. Now, this is an example of extracardiac masses within the liver. We can actually see a gallstone. In the left-hand image, you see a gallstone here. There's an echodense area surrounded by an echolucent area that's really consistent with the gallstone at the rim of the liver. So we can occasionally see this on ultrasound and some of the subcostal views. And then you have all seen this as well, but you can often see atelectasis in the lung space or the pleural space on echocardiogram. Often on personal lung access views or the apical views, you'll see a pleural fusion or the lung space, and in that you can see mobile tissue that's actually atelectasis and not something within the heart itself, but it's just atelectasis of lung tissue. So in the last couple of slides, I want to review again some of the common intracardiac masses that we can see within various chambers of the heart. And so I encourage you, when you see these questions on your boards or in real life, first to think about the chamber that you're seeing in and think about what's most common in that chamber. And so this is a nice schematic that goes through each of the chambers, the left and right atrium, the right and left ventricles, the pericardium, and the valves to kind of identify things that are more likely to be seen in those particular cardiac structures. So really commit this to memory, not only for the boards, but in general for your practice. And this is another way that we're showing that schematic with some more detailed information about tumors, either benign or malignant tumors in various chambers of the heart. So pay attention to this, recognize this as well. Here are the references in case you're interested in going back looking at some of the primary documents and literature regarding this. And then as always, good luck with your test. And remember that you have the brains in your head, the feet in your shoes, and you can steer yourself in any direction you choose. And good luck.